Hello and welcome to JAMA Network Open Conversations. I'm Angel Desai, Associate Editor for JAMA Network Open. Today we are speaking with Dr. Shama Cash-Goldwasser and Dr. Tom Frieden about masks during pandemics caused by respiratory pathogens, evidence and implications for action. Welcome to the both of you. To begin, can I ask you to please introduce yourselves?
Sure, thank you. Glad to be here. My name is Shama Cash-Goldwasser, and I'm an infectious diseases physician and epidemiologist. I analyzed and interpreted emerging scientific evidence on COVID-19 and pandemic mitigation strategies while I was a science advisor at Resolve to Save Lives.
And I'm Tom Frieden. I was formerly director of the U.S. Centers for Disease Control and Prevention and New York City Health Commissioner, and I currently am president and CEO of a nonprofit organization called Resolve to Save Lives.
This is the first time that we've had the pleasure of discussing a special communication on this podcast, and I'm so excited that this is the one that we're going to be talking about, because this is clearly a topic that is of considerable interest, not only to me, but also to the public as well. Can you just start by giving a brief overview of the state of knowledge related to face masks during pandemics?
So there are many well-designed studies showing that masking, including in the community, can reduce the spread of SARS-CoV-2. And we have data also suggesting which types of masks are most protective. And we also have well-designed studies showing that mask mandates reduce the spread of SARS-CoV-2. Although many studies support the effectiveness of masking in the community, very few of these studies are randomized control trials. However, the relative lack of randomized control trial data does not lessen the validity of the existing evidence I just mentioned.
I would just add that there is unfortunately a lot of controversy about masks. And although no measure, including masks, is perfect for protection, and although our knowledge isn't as good as we wish it were, there's a lot we know with a high degree of confidence that masks can be very helpful, both for source control and wearer protection. In other words, if someone who has COVID or another respiratory virus wears a mask, they're much less likely to spread the infection to others. And if someone is in an indoor space and exposed to the COVID virus, especially if they wear a high quality mask like an N95, they're much likely to get infected. And those simple observations have unfortunately been lost in the public discourse and sometimes even in the scientific literature.
In your piece, you talk about various tiers of evidence as they relate to face masks. Can you discuss what those are?
Sure. So one of the things we discuss in our piece is the hierarchy of evidence, as you mentioned. And what we discuss is that randomized control trials, or RCTs, are not necessarily superior, although they are often referred to as the gold standard. And indeed, in clinical medicine, there are important assessments of medical interventions to treat various conditions that have been performed in RCTs. But RCTs are often impractical to conduct in many areas of medicine and public health. And like any other study type, they have weaknesses such as limited external validity, they can be expensive to do, and they can take a long time to do. And they, like other study designs, can have methodologic problems. And so what really needs to be assessed for every study is how it was designed, conducted, analyzed, and interpreted. And in public health practice and in medicine, evidence that does not come from RCTs is almost invariably used, and many effective policies and recommendations have never been assessed in an RCT.
I think this is worth really emphasizing because there is a misconception, as Shama says, that RCTs are the gold standard. And for certain types of evidence, they certainly are. But RCTs are not the gold standard for all types of study. For example, when it comes to studying masks in a pandemic, it's very difficult to do an RCT. There were only two that we know of that were done during the COVID pandemic. One of them had some methodological problems and showed a tendency toward protection, but not statistically significant with a small sample size. And the other, with a large sample size, actually did show protection. But RCTs are far inferior to the weight of other evidence especially when it comes to public health interventions. That's a big difference from clinical care, where an RCT may well be the most important form of evidence.
I think these are really important points. You've mentioned the challenges with conducting RCTs for masks during a pandemic. Why haven't there been higher quality cluster randomized trials or other even observational studies of masks or other respiratory protection measures like HEPA filtration or even gloves and hand hygiene previously or during inter-epidemic or pandemic periods?
In terms of during the COVID pandemic, there were ethical issues and feasibility issues that may have precluded conducting RCTs. This was a pandemic caused by a novel and lethal respiratory virus. And RCTs take time to fund and design and implement and conduct. They can be challenging to adequately power if there's fluctuating exposure, that is, transmission of SARS-CoV-2. And as Tom mentioned, that there was one RCT conducted in Denmark that was underpowered to show statistical significance of their findings. There may also be crossover. It is not possible to blind participants to the use of a mask or no mask. And if an intervention carries social meaning, or if there's fear of getting a disease, you may have crossover between the control arm and the intervention arm. And then also, it's hard to maintain perfect adherence. And while imperfect adherence with the intervention may mimic real-world conditions, if there is imperfect adherence, those data can be pretty hard to analyze.
What would you say are some of the barriers to being able to stand up large networks, for example, in the US as compared to other countries during COVID-19 to study preventative measures such as masks or to do multi-institutional or multinational studies for infection prevention in general?
It's not so much a mask issue, but when it comes to clinical outcomes, the US was really handicapped by two things. One is the lack of standardized health information because we have health records in many different electronic health record systems. And the second is the logistical and administrative challenges of collecting that information. If you look at the United Kingdom or Israel, where they have relatively unitary electronic health record systems, they were able to rapidly get very powerful clinical information. That's not so much an issue for masks as for clinical outcomes. When it comes to masks, really nowhere in the world can you do the kind of immediate, rapid, high quality study that would be a large RCT. Actually, Bangladesh did one with hundreds of thousands of participants and showed protection. But that's not really the need. The need in public health emergency is for rapid data that gives us the best available information with the methodology that can be used at the time. And that may involve case control studies or cohort studies, cross-sectional studies, a variety of methodologies that can give us strong information on which to make decisions. Because the bottom line is every time we make a public health decision, it's made on the basis of the best available data, never on perfect data. That's why we always say, based on what we know now, here is what we're recommending. We give the reason for why, and we give what we're trying to do to find out more so that if we learn something different, we will change that. To give you one example in the mask space, we still don't have as definitive information as we would like on the importance of different mask types. And it does appear that particularly for wearer protection, better or more tightly fitting, more protective masks, such as an N95, is probably superior to a surgical or procedure mask or a cloth mask. But there are differences, and there are new mask types being developed, like elastomeric respirators, that may be very important in a future pandemic.
This makes a lot of sense. Looking towards the potential next epidemic or pandemic, how do you think we can best direct our efforts in the research space on masks? You've mentioned a couple just now, but what other efforts do you think can be made to try to obtain the best quality data we can to be better prepared next time around?
I think one thing that's very important, and we can get to future efforts, but I think it's important to understand the totality of the evidence that does exist and to really, as we've been discussing, not look to just one particular study type, but to really appreciate that there are a lot of data out there. We have a lot of studies, including observational studies that are of high quality from the COVID pandemic, from laboratory settings, from real world settings. And so it is important to understand the totality of the evidence that we do have. And in terms of future research efforts, there are ways in which we can rapidly generate data, as Tom mentioned, without implementing an RCT. There are different study designs that can be used that you can rapidly gather data, observational data, and do really intelligent and sophisticated analyses that yield really valuable results, including what types of masks are most effective in which settings.
I would just add that we have to recognize that nothing is perfect, neither data nor interventions. And in a pandemic, we're going to need layered interventions. Masks will be an important layer. We hope that vaccines will be a quickly available layer as well. But we got pretty lucky this time around. We have a vaccine that reduces the risk of death quite substantially, and it was available within a year. Uh, there are other pandemics, HIV, malaria, tuberculosis, where we've been working toward a vaccine for decades to a century. Whether we'll be able to develop vaccination quickly really remains to be seen. And that's why other measures, such as masks, are so important to prepare for, with supply, including better quality elastomerics, and more information about how they're used, how they can be best used, and how to mitigate some of the harms of them, such as the challenge of communicating effectively with patients or in other contexts.
And how can we give more attention to infection prevention research in general?
It's a great question. When we think about the research gaps, often our minds go to vaccines or antibiotics, and those are really important research gaps. But there are other research gaps in how can we best protect healthcare workers? How can we best protect patients? Are there any ways we can identify the risk of a super spreader event or of highly infectious patients? We oversimplify infectivity in the concept of R0, or the average number of patients in a susceptible community that one infectious patient may infect. In fact, in most infectious diseases, there is huge variability, and certain patients are much more infectious. If we're going to reduce the risk in healthcare facilities and elsewhere, we need to plan for and, if possible, identify those who are most likely to spread infection, the procedures or activities most likely to spread infection, whether that's bronchoscopy in a hospital or choir singing in the community, and reduce the risk in those environments.
This has been a really excellent conversation. Before we wrap up, I wanted to give you an opportunity if there are any final thoughts regarding this topic that we haven't covered.
So much became so controversial during the COVID pandemic. And unfortunately, the result of that is preventable infections and preventable deaths. We have powerful tools to protect people. Vaccines are the most powerful. Masks are also important. Although we're not going back to the environment of mask mandates and widespread masking, we've learned a lot. If you look at East Asia, where masking is common, if someone is ill and has to go outside or is concerned about exposure in a subway or other indoor areas, they wear a mask. There's no negative stigma. It's considered respectful of others. If we got to that kind of place, which we're frankly a long way from today in the United States, we'd be a lot safer.
A couple final thoughts from me. There will be future epidemics and pandemics of both known and novel pathogens. SARS-CoV-2 is not going away. And we do anticipate that new infectious diseases will emerge. We, as Tom mentioned, have a lot of data now to suggest that masks are a critical tool that can effectively reduce the spread of SARS-CoV-2 as well as other respiratory viruses. And I think it's important that we understand the data and evidence that we have. I also think that it's important to recognize that we do continue to learn that science is not static and there are still knowledge gaps, and hopefully those will continue to be filled in. It's also important to recognize that in times where there aren't mandates or where there isn't widespread masking, that the onus does often fall on individuals to decide how they're going to protect themselves. And there are data to guide those decisions as well, some of which we've outlined in our piece.
There's some powerful thoughts to end on. Thank you so much to Dr. Shama Cash-Goldwasser and Dr. Tom Frieden for speaking with me today about this very important topic. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.